in New South Wales, they do FONT.
So when it comes up, should be FONT, not.
And FONT is a great program, and I actually tried to get it for us because they've now moved from New South Wales into Canberra, but it just was taking too long money. So that will be, you know, something that I'll revisit later on because it is a really good program. And that saves. So we didn't do RANZCOG in New South Wales. Everything was FONT and it was in-house. We did the quality, the training for educators, and it was all in-house. So it saved $10,000 a year on RANZCOG. Mind you, I really like the RANZCOG. So severe early onset fetal growth restriction is part of the spectrum of pregnancy complications, which include preeclampsia and abruption, which result from defective maternal spiral artery conversion. Deficiencies in the first and second waves of trophoblast invasion result in inadequate conversion of high-resistant maternal spiral arteries to the low-resistant channels that normally perfuse the placental chorionic villi. So they're just telling you at the trophoblast point, you know, when you're having development of your cell, that that's where the problem lays, and that's why they're developing inadequate spiral arteries.
And usually it's due to some sort of maternal disease?
Well, they don't know. They don't know.
They haven't pinpointed why.
So we don't know what preeclampsia, we know what preeclampsia is in terms of the signs and symptoms, but we don't really understand. There's lots of theories that are bound about it, like, you know, placental implantation or defective placental implantation. We know that the spiral artery is affected maternally.
There's a lot of work going on with some colleagues of mine in PNG because if malaria, particularly in pregnancy, has a similar, consequence. So there's lots of studies there helping us understand the mechanisms around preeclampsia because of the work we're doing. We're doing placentals, we're doing Doppler flows and all sorts of things in pregnancy repeatedly and taking samples of placentas and women that have known malaria, and there's a very close association between women that have 1 or 2 doses of malaria in pregnancy have similar problems with their fetal outcomes.
Okay.
And when you look at the placentas, they look the same. The spiral artery interruptions are similar, and that vasoactive response that gets, you know, constriction, vasoactive response, hypoxia, and it kind of goes round with malaria. So yeah, I think we're finding out more and more, but it's not going to explain why it happens to that person or not the other.
Okay, so in fetal hypoxemia, there's an increase in the blood supply to the brain, myocardium, and the adrenal glands. So we know that they're the most three important organs in terms of survival. That's for anyone, not just the fetus. And reduction in the perfusion of the kidneys, gastrointestinal tract, and the lower extremities. So this is where we're, you know, shutting down a little bit to be able to maintain that central perfusion to those 3 vital organs. This is essentially a redistribution of the fetal cardiac output favouring the vital organs. It is possible to demonstrate enhanced perfusion to the vital end organs by Doppler studies, including that of the fetal coronary arteries, for instance. So the most common assessment of the fetal arterial circulation is that of the middle cerebral artery. So what they're saying is that they can look at the middle cerebral artery on the fetus in their Doppler studies, and they can pick up if there's increased perfusion, and if there's increased perfusion, that tells us that there's reduced perfusion to all of those other areas, which tells us the baby is suffering from hypoxemia. Isn't that cool?
That's amazing.
I reckon that's really cool.
Yeah, I get excited here.
Can you say that again? Sorry.
So what they do is a Doppler study of the cerebral artery. Yeah. So they're looking at the cerebral artery because if you have increased perfusion, so by perfusion I mean increased oxygen because there's increased blood flow to that area.
Yeah.
If you have increased perfusion to the brain, the heart, and the adrenals, which is what happens when we've got reduced oxygen and the chemoreceptors pick it up, they can actually see that it's increased in perfusion to the cerebral artery. And that means that it's reduced in all those other places because the baby has pretty much peripherally shut itself off to be able to perfuse those vital organs.
The reason I ask is not just to increase understanding, but we had a lady out in Hopevale that had actually reversed cerebral artery flow, and they thought the fetus
Gonski?
was wrong. Like
The
the
doctor was
baby
wrong.
was fine, but because they
Reversed. Jeez.
it was one of the teachers actually, Caucasian lady.
Yeah.
And then Steve wasn't very sure, so he had to
Refer it off
refer
and
it
consult with
off.
someone
Yeah,
else.
but it came back all right, but it looked
Yeah.
very suspicious, and in fact it came back with possible fetal demise, like to follow. And
We would be
he said-
worried about like a hypoxic brain injury.
yeah, but it was fine.
And if you think about it, now these are not real numbers, okay? I'm just using them. Let's say that normal flow to the brain, to the cerebral artery, is 5 mils of blood.
Yeah.
And then they do a Doppler and it shows 10 mils.
yeah.
So they're able to see on that Doppler that there's an increased perfusion to the brain. So then they start questioning, why is there an increased perfusion to the brain? If there's increase to the brain, there's increase to the heart, and there's increase to the adrenal glands. And that means it's decreased everywhere else because that baby is fighting for its life.
Yeah, it's just like an adult, he's got essential organs sparing.
Yeah, it's exactly the same as us.
Compensation, isn't it?
Compensation.
That's why you got the big heads and the
Got the
skinny
big
body
bits.
bodies. Keep the whatties?
Keep the big bits on.
So we know that we can do a venous Doppler, we know we can do a cerebral artery Doppler, fetal venous Doppler, so we're looking at ductus venosus. So in fetal life, the ductus venosus shunts a proportion of oxygenated blood from the umbilical vein to the inferior vena cava at its inlet to the heart. This proportion constitutes 30% of umbilical blood at mid-gestation, and by 30 weeks falls to 20% and remains stable. Hypoxemia increases shunting through the ductus venosus as part of the preferential redistribution mechanisms of the growth-restricted fetus. The ductus venosus has a typical waveform as a result of its relationship with the right side of the fetal heart. The first peak indicates systole, the second early diastole, and the nadir of the waveform occurs during right atrial contraction. I don't know if that's going to be able to show us. I can draw you a picture though. It just doesn't tell me, but thank God Mark will be here to explain it to us on Thursday. And that's really important when you've got your babies and we're resuscitating. You know, we talk about neonatal resuscitation. We talk about putting SpO2 probes on the right hand because they're preductal, so right hand to a right wrist. And that's because of that duct, because it's shunting from the right ventricle, not the left. So there's a point where it meets with the aorta that it's actually going to give you deoxygenated blood. So if you're taking a SpO2 on the left hand, you're potentially getting postductal, and that means that you're going to get deoxygenated blood. So it will look like it has a really low oxygen saturation. To be able to see what's how the baby is being cerebrally perfused, it needs to be on that right hand side before that duct, because that shows you exactly what's coming from the left ventricle to the aorta, which is what's going to the rest of the body.
And is that something that needs to be maintained throughout that, I mean, how long is that relevant for?
About 48 hours.
Okay.
And that's individual too. So about up to 48 hours before the duct closes.
Let's have a patent ductus.
Okay?
A
Patent ductus.
Then you go, oh, have a fix.
You've got half focus. So with increasing myocardial hypoxia as a result of failing compensatory mechanisms. So what were our compensatory mechanisms? Increased heart rate, increased cardiac output, shutting down to non-essential organs of the body, and our three essential organs.
Brain, heart.
Adrenals.
Perfect. Remember my dance when you're in the new dance? Changes in the ductus venosus waveform become evident as pressures in the fetal right heart increase with cardiac dysfunction. This begins as an increase in ductus resistance and deteriorates to an absent or finally reversed wave as blood flows in a retrograde fashion through the inferior vena cava to the ductus venosus during atrial contraction. Okay?
Amazing.
It is pretty amazing. These are my favourite things.
But we're not going to be examined on that, are we?
Because I don't recall, do you, Vera? I don't recall anything on.
Waveforms.
No. It's just the understanding that if someone had, like, there might be a question that says that it had poor Dopplers or something, and that's going to be relevant in the CTG that you're reading. So it's that underpinning knowledge as opposed to being specifically or directly questioned on that. Prospective studies consistently show that ductus venosus flow is the best cardiovascular variable in the prediction of perinatal outcome in severe early onset fetal growth restriction. The prognostic and diagnostic information gleaned from biophysical profile scoring and Doppler testing are largely independent of each other. While we await results from a multi-center prospective randomized trial comparing cardiotopic criteria and ductus venosus Doppler waveform changes as criteria for delivery, we need to continue an integrative approach in our monitoring of the IUGR fetus based on our current understanding of fetal physiology, which that obviously makes sense. That's obviously just a little bit of a summary. Let's see if we get that component. So are we all okay with that part? Well, as okay as we can be without having full understanding of the actual test, like how to interpret the test. But do you feel like you've got understanding of what the test means, why things are occurring?
Yeah.
As opposed to actually being able to interpret the tests themselves, which I'm really sorry is outside of my scope of knowledge. So I'm not very helpful. Can I keep talking?
Yeah.
Alright, so we're looking at fetal growth restriction. So assessment of fetal growth and well-being is one of the primary goals in antenatal care. Fetal growth restriction refers to a broad clinical entity where the fetus is affected by a failure to thrive due to adverse environmental or genetic factors and is manifested by a lower than expected birth weight. Now I guess that this is the point for me, because for me, we've discussed stuff. Okay, I can pick up in my head why I've got a fetus that's growth restricted based on the physiology. So this is where it's your turn to maybe explain to me what you think in relation to why this baby is failing to thrive. So what's happening that's causing this baby to not be able to thrive? Why is it not growing and developing?
Hypertension.
So hypertension would be a cause. Why would hypertension be a cause? We're talking maternal, yeah?
It's not getting all that glucose and oxygen to make energy and then grow.
So why is it not getting it?
Because there's resistance in the vessels.
Why is there resistance in the vessels?
Because it
Potentially. What happens in hypertension? That's exactly right.
there's vitamins in there, it's just not normal words.
What are the vessels doing? Vasoconstricting.
Empty.
And constriction of vessels means what?
Less